Welcome.
Thank you. Thank you.
All right, so what I guess we'll go ahead and do is, here's our PowerPoint. We're going to do this really quick. Can you guys all see this?
Not yet.
You have to share screen.
Sorry. You would think I
right
would.
down there.
There it is.
Yeah.
Dun, dun, dun. Okay. And obviously, since it's a small group, you guys either are calling in or have your cameras on, so you kind of know this tech check information already. And you're all muted. So, and then of course, if you have any questions, just put them in the chat box, and we will get to them. So yeah, since it is a small group, we kind of went through a little bit of introductions beforehand. I think everyone, so Laura, you're just the only one. I know who you are, but do you mind just sharing your title and organization with us?
Sure. I'm Laura Warner, and I'm Deputy Director of Operations at San Juan Basin Public Health.
Great. Thank you for joining us.
Happy to be here.
Okay, there it is. And then we have Nazali. Did I get it right? Perfect.
Yes, you did. Yeah, good afternoon. I'm Nazali Workman, and I'm attending this meeting in behalf of Dean Paula Kirshner of Pueblo Community Colleges, and I am an academic excellent administrator.
Perfect. Thank you for joining us.
Well, thank you.
Okay, and Miss Dawn.
I'm Dawn Marie McAllister, and I work for Southwest Health System in Cortez, Colorado, and I am the payer enrollment coordinator, and just kind of, if there's a project, they see if I can handle it.
Great. Well, thank you for joining us.
I guess
nice to be here.
The only thing about having our whole screen like this is we can't see if anyone else joins.
No, it's still good. Okay. You can see them pop up. Okay, so we'll go ahead and, so obviously, I'm not sure if some of you saw the agenda or not. I can switch it over when she comes back in. Okay. So yeah, so we just did our introductions. Look at that, we're on time. We did 5 minutes of it, it's perfect. So now, obviously, Kate Hartzell is our new executive director, and we're excited to talk about this subject. And so she's going to kind of lead the way with an introduction to localizing competency-based behavioral health education. So I'll go ahead and take that away, unless you want to. I'll show everyone her beautiful picture. That's Kate too.
You can go to my first slide actually.
Okay.
And you guys, I think this is, since there's 4 of us or 5 of us, it's going to be more of kind of a, can you go to that first slide above that one? Yeah, thanks. It's going to be more of a conversation, but it's interesting to see kind of, even though there's just a few of us here, I think that speaks to summer, and it also speaks to maybe the idea that we need to think about the Sector Partnership Alliance, the Healthcare Sector Partnership Alliance, and how to kind of, decide. This is the end of our funding stream. And like Christina said, I'm the new executive director, so I just came in to Southwestern Colorado AHEC, but it does seem like at some point it's going to be time to rethink with some community input, including yours, how to move forward with having this alliance and whether or not it needs to kind of morph into something different. So we could talk about that at the end if anyone has any ideas about that. But in the meantime, I just wanted to present a little something to have people think about, looking at how we train behavioral health kind of professionals, either existing behavioral health professionals, but also our future behavioral health professionals, and and thinking about everything from an early part of educating our new professionals, as well as how we can enhance trainings that are going on or that could be offered for existing health professionals that are actually practicing in Southwestern Colorado. And that's what the conversation today is going to be about. And it's interesting because we have, you know, Dr. Warner, who's got both a clinical as well as a public health perspective, and then Nazali, you have a kind of education, student excellence kind of perspective. And then Don Marie, you have more of a healthcare systems kind of perspective. So it is kind of interesting, you know, even in a small group, we have a couple different perspectives. So I'll try not to bore the socks off of you, but one of the things I wanted to start a conversation in this community about is thinking about how to understand how we take competency-based training, so training that is related to a larger discipline like behavioral health, especially clinical behavioral health, for example, or behavioral health in a primary care setting, and how we localize or try to figure out how we can change or enhance those kinds of skill sets for our specific communities here in a rural setting, in a Southwestern setting, and in a distinctive cultural setting. So I hope that kind of makes sense. That was some of the things I wanted to think about. Also kind of thinking about moving forward with talking to people in the healthcare sector Partners Alliance about even continuing to move forward in partnerships for funding opportunities for these kinds of educational experiences. So I hope that makes sense. As Christina said, I'm a new executive director, but my background most recently was in building public health, an undergraduate public health program for the Navajo Nation. And so I just wanted to start really briefly just showing you just a few things, and it's going to be a real brief kind of touch upon. But when I was working for Navajo Nation, we were building public health programming that used public health competencies that have been dictated by national professional workforce, you know, organizations. And we were incorporating what our community on Navajo Nation, our communities, plural, on Navajo Nation were telling us needs to be included when we're looking at public health in that specific set of communities. So can you slip that next slide? So again, this is really a quick introduction, but and I must admit that I am obviously not Navajo and am not a cultural expert. So when I was doing this work, I had advisors that were Diné that kind of advised me on how best to approach public health from this different cultural perspective. This is just a depiction of one of the many kind of philosophical beliefs for the Diné about the four directions. And everybody, you know, we all live in this Four Corners area, so some of you might be familiar with this, but this is a deep set of philosophical kinds of beliefs that are interconnected with all kinds of things like the spiritual world and the landscape. And it's a four-direction model with, you know, starting at the east where the sun comes up and goes around south, west, and north. And it's also related to four sacred mountains that delineate the Navajo Nation. And so in Diné belief, there's some characters and different kinds of I don't know, maybe even behaviors that are related to this model. And so if you show me if you'll go to the next slide, we used this model, and again, I'm not going to get into the particulars, and we related it to a more kind of traditional Western model of public health. And these are the 10 essential services of public health. This is kind of when you practice public health, these are what you tend to be a part of, either touching on all of them or a piece of all these different things. So if you'll go to the next slide. And again, hopefully you'll understand what I'm getting at here. I didn't want to kind of lecture you on these, but we kind of found a way with our cultural advisors to overlap some of what is part of a traditional model like the Four Directions model with a Western perspective on looking at public health. And we were able to overlap, you know, that east, south, west, and north model into a Western model of public health. So if you go to the next slide. And we did that by working together with the community. We had all kinds of community advisors. We had students from the tribal college that were helping with the program development. We had the Navajo Nation Department of Health. We had their community health representatives, which are their community health workers, and all of them were feeding us information and looking at our modeling and looking at our curriculum content to decide, you know, whether or not it was applicable to teaching about public health in that arena. And so we have a similar thing going on potentially with something like the Sector Partnership Alliance, where we have Dr. Warner from San Juan Basin, you know, we have people from the community, we have people from academic settings. And so that's kind of the model that we use that's actually kind of happening here. And then just to show you, next slide, thanks. There's program competencies that are also related to public health. So these are the different skills that if you're teaching public health, you want your students to come away with. And these are just a couple, again, I don't want you to read them, just the idea that there are these skills and knowledge sets that we want to teach people when we're teaching them this, at least this part of health. And healthcare. And then if you go to the next slide, we did the same thing with the program competencies. We overlaid some of what we were hearing from our traditional kind of advisors. And so we keep the core competencies of public health, so our students were part of this larger Western discipline, but we also included important cultural beliefs that more adequately addressed public health issues on Navajo Nation. So, nope, that's okay. To go to the slide with the woman in the blanket, right there. So these are some of the things that ended up in our curriculum that were different than what you might see at another school in the nation or another program teaching public health. So we incorporated what our communities were telling us. And again, this is not the same for what we're going to be looking at in terms of Southwestern Colorado. You know, we don't have, you know, Navajo Nation had a very specific set of traditional beliefs that could be kind of tapped into. It's a little less straightforward, but this idea that you can teach different kinds of healthcare disciplines that are even competency-based and think about ways that you can make them more community-specific. So if you'll go down to the next. And so what I wanted to look at today, and that's just an introduction for this idea about trying to, again, think about ways that we can make our trainings community specific to address our own community issues and possibly do it in such a way that it more adequately addresses our specific, in this case, behavioral health issues, but also does it in a way that incorporates the strengths and assets of our communities. Is this making sense? Does anyone have any questions so far?
Makes sense so far.
Thank you. Thanks. Okay, so what I was looking at for today's kind of conversation with you all, I was hoping that we could have a conversation. Again, there's not many of us, so it might make it difficult, but there are core competencies out there for behavioral health providers, and in this case, I chose the ones that were related to behavioral health provision in a primary care setting because I feel like that's a lot of what I hear when we talk about these issues, at least so far when I look at data and talk about behavioral health with people about behavioral health programming here in this part of Southwestern Colorado. If we're not talking about upstreaming and, you know, developing programs, but we're actually talking about the provision of behavioral health care. So I pulled these competencies out of, you know, looking at a primary care setting, and the next slide. And the document that I used was one that was sponsored by AHRQ, you know, the Agency for Healthcare Research and Quality, out of the feds. And they had a specific definition of behavioral health. They had an emphasis on a team of primary care and behavioral health clinicians. So some of these that we're not gonna spend a lot of time on it today, because I didn't, those of us on this call and kind of a community look at these things, we're not really talking about clinical training, but how we can provide either pre-health professional kind of exposure, as well as perhaps supporting people while they're being trained as behavioral health professionals, and then potentially continuing education for existing behavioral health professionals. So we're not really looking at clinically, but working with patients and families using a systematic and cost-effective approach to provide patient-centered care for our population. And then it's this part that we may kind of decide to look at today. We want to look at mental health and substance use conditions, health behaviors, life stressors, crises, stress-related physical symptoms, maybe not that so much. And then I don't really know if we're going to ever talk about, exactly looking at healthcare utilization related to behavioral health, but that was all part of that definition for the AHRQ. So next slide. So there were 8 competencies, and I think I was just thinking we would kind of, especially with a small group, maybe we'll just look at one of them, because some of them are specifically related to clinical care. So you can see that if you don't know much about competencies, they basically lay out, so people do a lot of research on figuring out in the workplace what exactly people need to know. So in healthcare, it's going to be exactly what you need to know to carry out if you're a clinician, to carry out your clinical practice, if you're a public health person, to carry out public health programming and research, et cetera, et cetera. So they come up with a bunch of different competencies, and you can see a couple here about identifying and assessing behavioral health needs as part of a primary care team. So that's all about diagnosing and understanding mental health, engaging and activating patients in their care, working as part of a primary care team. Again, these are kind of clinical, and help observe and improve care team function and relationships. But it's the next one, number 7, is to provide culturally responsive, whole person and family-oriented care. And this is where we get into, it says, behavioral health providers in primary care employ a biopsychosocial model, approaching healthcare from biological, psychological, social, spiritual, and cultural aspects of whole person care, including patient and family beliefs, values, culture, and preferences. And this is the kind of place in training our behavioral health professionals that we could potentially get involved. So if you could go down, and actually, can you go down probably 2 more? Yeah, so here's that particular competency I was talking about, providing culturally responsive, whole person and family-oriented care. Again, using that biopsychosocial model, looking at it as something bigger. It's also a kind of a social determinants of health look at behavioral health care. And the next one asks some questions related to, for example, how social factors impact behavioral health. And they have a whole list of different ways to do that. Go to the next one. As well as cultural and spiritual factors. They can also come into taking into account gender identity, sexual orientation, disability, ethnicity, race, age. It can be geography, can be, the demographics of a certain region. Like it says, it can be cultural related to different cultural groups in a region. Okay, next slide. So what I wanted to ask today is to see if we could have a discussion. If we were going to work on creating as a community ways to both potentially find ways to draw in more behavioral health professionals in our community, because we do overall have, a physician healthcare, in some areas of healthcare provision, a scarcity of providers. So if we wanted to create a way to do some training to get people well informed about how to approach behavioral health in this part of southwestern Colorado, what kind of factors affect our health concerns, and then I wanted to have us think more about how we could develop training materials for southwestern Colorado. Does that make sense? I just talked at you for 10 minutes, 15 minutes, so I'm sorry about that.
Yes, making sense.
I don't, I can't speak for the other areas, but I know that Cortez specifically has a fairly high percentage of retirees. And even if they're not retired, people above 55, 60, that kind of thing. So they have a very limited understanding of behavioral health. Their background is you don't do that kind of thing. You just don't talk to people about that kind of thing, especially strangers. So that's a huge issue on my side of the world.
Yeah, that's really interesting, because there's a number of things, that you bring up so there's, first of all, that whole issue. And actually, if you do a deep read of these behavioral health competencies, of course, there's a huge part of it is all about the stigma, of dealing with mental health and mental health issues. But this is interesting, actually, and I haven't had a chance to look at data, but I think that that's a change in our communities in this part of southwestern Colorado. I think there's always been people who have retired here, but I feel like, and maybe it's related to baby boomers and population demographics, but I do feel like those numbers are going up. So not only attitudes about mental health, but also their specific mental health issues related to aging and people age 65 and older. So that's super interesting. Yeah.
Thanks, Dawn, for sharing that.
Yeah.
You're welcome. Okay, everybody's really quiet, so I'll just go again. Another concern on in Montezuma County is poverty. There's a whole level of not necessarily stigma, but okay, so maybe I want to go see a counselor, and even if maybe I can find a place that I can afford to do it, okay, but I have real issues that are affecting my mental health, so to speak,
Mm-hmm.
as an example,
Mm-hmm.
and there's not a lot that I can do about it. So, how do you help people get through that? Yes, you are in poverty right now, and there's not a lot that you can do about it in this position. So how can you think more positively, even in the midst of a situation that you just really can't change at the moment? I think that's something that people need to think about and address when they're looking at how can I help this particular group of people.
Yeah. Yeah. I think, and specifically rural poverty too, which has its own kind of, it looks its own way. It has its own set of characteristics.
Yeah.
And I think that's again, looking at that whole social determinants kind of modeling that, I know that like San Juan Basin is involved in that, public health programming that's looking at those bigger issues of how things like you're saying, poverty obviously has a huge impact on mental health and the stress of poverty and all the related issues. So yeah, but that's that is a big thing about having the social determinants of health being taught, for example, to clinicians, I think in behavioral health programs, there's maybe more of that, but it's kind of an interesting topic to raise.
So this is Laura. I hope it's okay to kind of switch the topic a little bit. But one of the things I'm thinking about is Colorado is just wrapping up 3 years of state innovation model funding.
Oh, yeah.
That originated with the Centers for Medicare and Medicaid Innovation. And really the goal for that has been to significantly change in a positive way the provision of behavioral health care and the like in the state. And I mean, a lot of work has been done. So I'm just kind of wondering how this conversation fits into what has been going on with SIM. Yeah, because I know that there are a few clinical practices in the area that were SIM grantees and went through a pretty prescribed guided process on integrating behavioral health into their physical health practices. So there's tons of work being done in this space, and it'd be interesting to kind of find out, what are the gaps in the transformation that has been occurring, and what would something like this need to be to fill some of those gaps.
Yeah, that's really interesting. So, Laura, is something, do you see, so people have been working with these practices, is the idea behind a lot of that SIM work to somehow, I don't know, is that going to change medical education or behavioral health education? What's the idea behind where what comes out of that, all of that work? What's the long-term plan for it?
I don't think it's that far upstream. I think a lot of what the practice transformation was about was integrating behavioral health and physical health within particular specific clinics that were funded. Along with that, though, I believe that at the state level, there were some work groups that came out of SIM, and they created some educational documents. So I mean, the folks at SIM would be able to tell you much more, but we're a public health grantee of SIM, and so I'm sort of loosely aware of what's going on in the other arms of SIM.
Yeah.
But I think that they've come up with some educational documents that maybe practices could use, or perhaps even individual clinicians, to understand maybe the benefits of integrating behavioral health and some of the nuts and bolts of how to actually make that happen.
Yeah.
I do not think, although I could be wrong, that they're reaching as far back as training clinicians before they ever get to a practice. Okay.
And were there anything like CMEs or CEUs, or depending on who, was getting this training, coming out of that work as well? I mean, was this something that could be available to not a designated, kind of funded?
I think so, but we're like way outside of my the parts that I've been tracking. But let's see, I also am aware, and I'd have to do a little bit of research, just kind of looking through the archives of stuff I save. But there's a really great toolkit for primary care practices on how to address the behavioral health needs of patients. And I am not going to remember offhand which entity created that, but I guess suffice it to say, there are some really great resources that have been created over the last few years that I've been watching, and I think some of them are, just publicly available to whoever wants to use them.
Okay. Yeah. Thank you. Yeah. Sorry.
Oh yeah, I can try to track down a couple of these resources and just send them your way so that you're aware of them.
Okay. Yeah. Great. That's great. Okay.
Thanks, Laura.
Yeah. Thank you.
Sure. Yeah, we are working on a lot of suicide prevention work, and so that's not exactly what you're talking about, but it's absolutely related. So
Yes.
I track these things very closely, and so I guess there's a lot of things.
Oh,
Hello?
did we lose you?
I think we lost you.
Is everyone else on?
I'm on. Naz is on.
Oh,
Okay.
Oh, we lost her.
Oh, okay.
You can't hear me anymore?
Now we hear you. Now we hear you. Sorry.
Oh, okay. That's weird. I didn't change anything on my end, but I've been here the whole time.
Okay. Yeah. Well, and some of even what you think about, and this is happening, I know, in so many ways. So I don't mean to even suggest that these things don't all exist, but the idea behind, if we're thinking about doing training specific to Southwestern Colorado, what are the resources that people immediately think of to either inform curriculum or should be part of curriculum? Or if we were going to do, say we were going to come together in a work group and try to create experiences for Fort Lewis students, experience for visiting University of Colorado students, experiences for our high school students, and then even experiences for our practicing professionals. What are some of the things that immediately come to mind that would be so valuable, especially that are local, that are really distinctive to our communities?
Well, I guess I'll chime in again. I mean, I think certainly the early adopters of some of these more the behavioral health integration, I guess I'll use again. I think we really do have some local experts in town who've been through this. So
yeah,
just like leveraging the institutional knowledge that we have, it would be well worth the time.
You betcha. Yeah, I mean, are there people that come to mind immediately, or I mean, would it be this be a good thing to like pull a meeting? Because I know this work is being done, and it would be great to know more about, especially from you, who you see as really involved and educated about these things.
Well, so the practices in our area that were received practice transformation grants from SIM are Pediatric Partners of the Southwest, which is in Durango.
Okay.
One of the Mercy Family Medicine clinics, they have a few different locations. I want to say Three Springs. I'm not 100%, or maybe, well, yeah, I'm not 100% sure on that one. But one of the Mercy Family Medicine clinics, also in Durango, and then Dove Creek Clinic, I believe.
Okay. Yeah. Okay.
Hi, this is Amanda. I'm with Pediatric Partners. Can you hear me?
Oh,
hey, Amanda. Hello.
Hi.
Hi.
I kind of popped in late, so I only have caught the tail end of this, but I heard you Laura talking about SIM, and we were one of the first cohorts of SIM working with the behavioral health. So I'm not sure what you guys were talking about exactly. Sorry.
Okay, that's okay. Yeah, one of the things we were talking about was kind of leveraging the information that you guys gained in being involved in SIM and being part of that practice transformation, and how how that could inform future training opportunities for everything from our future to our current behavioral health professionals that are particularly serving the needs of Southwestern Colorado.
Okay. So so in our practice transformation with SIM, we focused on the integrated behavioral health and how we were going to use the behavioral health counselors within our practice mainly. And so we developed like child wellness homes, and just really focusing, looking at using different screenings like social determinants of health and all of the different screening tools that we could do and how we could integrate all of that into our practice, along with doing things like shared visits with the counselor, integrated visits, but the behavioral health counselors and our providers. So there's a huge range of different things that we worked on over the last few years, actually. So I don't know, as far as all of that as training for other people. I mean, we did a ton of work and can always share what we've learned and currently done. But I don't know, as far as like bringing training of new people, exactly what you guys are looking for. So
no, I think even some of what you just shared. So the idea is to potentially think about some of these things that you have implemented that are valuable in your practice, and think about what kind of skill sets or what kind of knowledge potentially facilitate those kinds of healthcare professional behaviors, if that makes sense. And I know it's really, I mean, it's kind of pushing people to kind of think about this, but just in thinking about how to create, for example, and of course, I kind of particularly think about new healthcare professionals or people who are right now in the middle of, like, our AHEC scholars, for example, that are right now in the middle of some kind of graduate medical education. If we wanted to think about how they could best become people who could practice and contribute to our behavioral health clinical or even just support setting here, what kind of skill sets could they bring? And so I don't know, when I hear you just talking about what you were talking about, some of the competencies about the professional workplace and relationships, right? I mean, it sounds to me like being able to work in a team, those kinds of things.
Yeah, definitely. And I'm the nurse manager here, and I also do all the telehealth and outreach clinics with Children's Hospital. So I'm not as enthralled in the behavioral health piece. I kind of jumped on as the person that was able to be part of this conversation, just to take information back. So actually, Dr. McMillan, Heidi McMillan, is our queen of the behavioral health here. And I can definitely talk with her and have her share what pearls she thinks would be most important for you guys and most helpful.
Okay, yeah, because and thinking about creating even thinking about training in behavioral health, thinking about creating even like a community advisory board that would be actively reviewing kind of ideas for educational opportunities for, in this case, because of this conversation, it's about behavioral health. But yeah, that would be great. Thank you for that. And I can talk to Dr. McMillan maybe sometime about some of this as well, or we can, see if we're going to be able to find a work group to come together. And I know I say work group and I can feel everybody like, but even one work meeting or something like that to kind of get things started, she would be probably a good addition. Yeah.
Yeah, definitely.
Okay.
I would like to mention something as well on the behavioral health. For example, CAC, the Certified Addiction Counselors, getting preceptors, getting internships like under a CAC 3, like in Pueblo, that's not easy. Students like Pueblo Community College, we offer courses, but getting them internships where students can get their hours, which is 1,000 hours for an addiction counselor 1 and another 2,000 hours for addiction counselor 2. Finding those internships for like certified addiction counselors is very difficult.
Why do you think that is?
Well, they're so needed. So I think, well, it's so many hours to get the hours. So I think maybe places think, oh, we're going to have to invest a lot in this employee when we really need the CAC, the Certified Addiction Counselor. However, getting the students and persons so they can actually be a CAC, it's difficult. It's difficult to get those internships. So I see, because, it's such a, addiction counselors are so needed everywhere, correct?
Mm-hmm.
But getting them their internships is very difficult.
Interesting. So you think it's the kind of thing where, trying to figure out a way to find more preceptors for them, or?
They have to work under a CAC 3.
Oh, that's what you were saying. Yeah, I don't know anything.
That's just one thing under behavioral that I see here, like in Pueblo, because I am the contact person for a HRSA grant for CAC.
Mm-hmm.
And that is just one of, I look everywhere and I know they need addiction counselors, but for students to get their hours so they can go out and be an addiction counselor isn't so easy.
That's interesting. And if you're having that issue, I think I didn't realize you were in Pueblo. If you're having that issue in Pueblo, I can imagine, that issue must come up. So do students at your PCC campus here in Mancos, is there CAC training there as well, or is that a program that's just in Pueblo?
They're just in Pueblo.
Okay, interesting. Huh. Okay, so that's more of like an internship preceptor. Yeah, great. Okay. Anything else come to mind for people about addressing, thinking about ways to develop kind of training that's very community-based?
Are we looking at continuing education type of thing, or community-based education? So, for example, down here at like you said, the Mancos campus, would they institute education that's specific to our community just because they happen to be down here? Or are we looking at continuing education type of opportunities?
Yes, actually both. Thinking about both of those things. How to make things a little more, trying to find ways to make sure our training is addressing our local kind of issues, and potentially making it culturally specific. And again, cultural specificity doesn't have to, a lot of people just kind of go straight to, and I gave you an example that was a little bit of a little bit kind of culturally specific in terms of Navajo Nation. But yeah, just trying to figure out what are the specific issues or things that could be addressed here in this part of the state, and whether or not it's unique. Well, it is unique, but how to kind of express that uniqueness in some of our training opportunities for behavioral health professionals. Did you have an idea about PCC?
Many moons ago, I used to work at a university, and I was just thinking that that would be very difficult for the schools themselves to put in culturally specific programs, because they would have to have a different program at each, especially like PCC, who has so many different campuses. How do they make sure that it's all accredited if they're doing that, if they're trying to do it per community? That's why I was just thinking more along the lines of, maybe working with the institutions to offer continuing education that would be culturally specific. And then potentially those courses could be a part of maybe, for those who are going through programs, potentially maybe elective credits or something like that. But
Yeah, exactly. No, I mean, that's what when I was talking about competencies, every discipline has specific competencies that have to be met, obviously, and the programs have to demonstrate that, to keep their higher learning commission accreditation or whatever, accrediting board is doing that for an academic setting. But yeah, exactly what you're talking about, either having, units that are devoted to this area, using examples, that are specific to this area, or even allowing students when they're pursuing independent research projects, or even a senior thesis or a senior internship, to do something that's very community specific. So that's, I mean, you're hitting it. That's exactly kind of what I was talking about, that you have these competencies. And in behavioral health, obviously there's things that people need to know, but what kind of things could enhance that learning that, makes it even more specific to our region?
Yeah, so that almost comes down to talking to the program coordinators and maybe even the professors themselves.
Yeah.
And helping them see what's needed in this community so that they can offer those examples in their classrooms.
Exactly, and that's what I was kind of hoping we could come up with today, is some of those examples, because you're exactly right. And I think, at least originally, there were some of those people were on this sector partnership. It's summer, for one thing, so anyone who's going to be in an academic setting, thank you, Nazali, by the way, are potentially not going to be available for these kinds of phone calls. But that's exactly right. Is if we were to hit up the people who are actually doing these trainings, what kinds of information could be provided to them to augment that training to make it from here? You know what I mean? I mean, you're doing it. It's exactly what I'm talking about. Are the things you're mentioning?
So for maybe training for them.
Yeah.
For the educators.
Yes, that would be amazing. Yep. Yeah, and then what we really need is that community advisory board to let us know what kind of things would go into that training, so that the people that are teaching our next round of behavioral health professionals are making it kind of localized. Yeah, but you're right. I mean, I think that's a great idea. A training, kind of training for trainers.
Yeah.
But at some point we have to, we would want to come up with content, and we'd want the content to come from our communities.
Has there ever been any interest in the communities to put together that, like a community-based, a work group?
Yeah.
So on that note, this is Laura again, and I just want to make you aware that San Juan Basin Public Health is leading a kind of La Plata County-centric, initiative to try and reduce our suicide rate in this area. So it wouldn't cover, all of the geographic areas that we're talking about right now, but we have pulled together leaders from lots of different sectors who are involved in behavioral health in our community to do this work. So yeah, I guess just, to not create something entirely new, and I think many of the people you need to talk to might already be meeting in some way or another. We should probably talk about what we have going on, so that you just have your finger on the pulse of, would that be a venue you might want to visit, or is this completely different? I don't know, but we should connect on that.
Absolutely, and that's exactly those are the things I wanted to hear today. I am, and all of us probably here with these ideas, tapping into what already exists to see if potentially it could be one of the conversations, or it could morph off of a conversation about, for example, suicide. Yeah, that's perfect. That's exactly, just to see if that one of your meetings, this could be something that is talked about. I think it could be, if it's interesting to that group. But yeah, definitely. Thank you, Laura. We'll talk about that. Yeah, and I didn't necessarily want any thing to morph out of this conversation today, because this was my point about this spa, is that it's going to change shape. And I think what we're definitely not interested in doing is redoing something that's already being done. And I think these are the kinds of things I wanted feedback on, both in terms of this topic today, as well as thinking about moving forward with, you know, the Healthcare Sector Partnership Alliance, and whether or not it would be better to support some other existing things that potentially are more topic specific. So thank you for that. Anything else that people have? I mean, obviously, this is a huge topic, and I feel like some of the feedback that I have been getting just from initial forays into talking to people about the Sector Partnership Alliance is that there's a lot, obviously, with very good reason, going on related to behavioral health and substance abuse and suicide. Those are big issues for our communities, and there's a lot of good work going on. And I think the idea that we all know about what that work is and that we can all put our energy behind, for example, what Dr. Warner was talking about, things that exist that that are doing really good work related to some of these issues in particular, that may be kind of a way that we move forward. Does anyone else have any comments, questions? Okay. Well, so again, we will be in contact. I'm sorry that I don't have anything kind of firmer for you about the future of the Sector Partnership Alliance. Like I mentioned, our funding is kind of coming to an end, and we're really trying to think about how we move forward with what I understand is a lot of good energy in that group. I don't have a history with you all. I'm really coming in at the end, but we will definitely be doing some kind of follow-up to see where people's interests kind of lie, where they think, you know, it might be a good way to move forward, you know, whether it's getting involved in existing work groups or other alliances and other organizations moving forward. So we will definitely be contacting everybody about that. And does any other comments, questions, ideas?
This is Chloe, and I feel like you're really hitting the nail on the head, because it's an interest for many of us, and you know, it's a huge need for our community. So I feel like there's already, like you said, a lot of really good work out there already being done, and if we can coordinate to where the resources can be spread further, or ideas can be made into realistic action that's actually helping our communities. I just think it's wonderful. Thank you.
Yeah, thank you, Chloe. Yeah, I think that's absolutely true. And, you know, when you hear Dr. Warner mentioning these specific initiatives, I mean, yeah, that are that much closer to being moved forward in relation to an issue, that's where we want to put our energy. So thank you for that. Anyone else?
Just this is Louisa for Rocky Mountain Health Plans. I'm sorry I'm so late. I had a meeting go over, and I'll just catch up when you send the notes out.
That sounds great. Thank you for being here. Appreciate it. Thank you.
And just to let everyone know, if they came on late, I do record this and I send it on, I put it on our YouTube account, so I'll send everyone the link as well.
Okay. Yeah, and if anyone has any further questions or ideas, my contact information was up, but feel free to email me. I would love to, know more about what you all are doing and know about ways to support you in that work and the work we do here at Southwestern Colorado AHEC. So thank you so much.
Thank you, guys.
Okay.
Thanks, everyone.
All right. Thank you.
Thank
Have
you.
a good day. Thanks.
Thank you. Bye-bye.
Bye.
Bye-bye.